Hello and welcome to Healthline 3. I'm Carrie Simmons. Today we're talking with nurse practitioner Zach Choate of Willis Knighton Cardiology. We're going to be talking all about heart failure, which is some really interesting facts that I didn't know, that you're going to enlighten us on a whole bunch of things about that. So we'll be taking your calls throughout the show, and as a reminder, please make sure you're in a quiet room with your TV turned down all the way before making your call. The number is 318-219-4569, and you'll see it at the bottom of your screen throughout the show. So thank you so much for being here, Zach.
Well, thank you for having me. It's an honor to be here.
Oh, it's an honor for us to have you. First of all, let's start with what a nurse practitioner does, because that's fascinating.
Sure. So a nurse practitioner is an advanced practice registered nurse who goes back to obtain an advanced practice degree, a master's degree or a doctoral degree that receives additional training to be able to diagnose and treat and prescribe and treat medical conditions. We work in collaboration with physicians in the state of Louisiana, and it's kind of a team approach of managing patients together.
It really is. And did you know when you became a nurse that you were wanting to be a nurse practitioner, or just kind of grow into that?
Not at first. I wanted to get into the medical field to help people, and just the more you get into it, the more I wanted to learn and continue to be able to help, and it was just the right path for me.
Isn't it great that there's that path? You want to learn more, and well, there's this, and actually positions, for you to go ahead and learn and just take on new stuff and new ways to do it.
Yeah, absolutely. There's always more to learn, and medicine changes on a constant basis. So you have to stay up with it and to continue to learn and grow with it.
Which is fascinating too. So you're constantly learning, constantly getting the new information and applying it.
Right? Absolutely. Yeah. So,
did you know you always wanted to be in cardiology?
I did. The heart's always fascinated me. It's just always been an interesting organ, and I've always enjoyed managing it and taking care of those cardiac patients. Yeah,
I've learned so much from talking to the doctors here especially about what the heart does. And so let's talk about heart failure. That term a lot of times can mean, let's bust a myth here, like heart failure. I always think my heart stopped or you're going to die. But heart failure, what technically is heart failure?
So heart failure is a condition where the heart either becomes weakened and doesn't pump blood flow adequately, or there's other conditions of heart failure where the heart muscle becomes thickened and stiff and doesn't relax as well. So it's an overall condition that we determine where the heart isn't working quite appropriately as far as the heart function.
And so what would the term be? Like, I have heart failure, is that a condition that you live with going forward?
Yeah, so usually once you're diagnosed with heart failure, it's usually a diagnosis that you carry long term. It's caused from many different issues, from ischemic heart disease, ranging all the way to viral cardiomyopathies. You'll hear the term cardiomyopathy used a lot, which is disease of the heart, but there's many conditions that can affect it and cause and develop cardiomyopathies in patients.
Okay. And once a heart gets to a certain point of failure or damage, does it ever get better, or does it?
So it can. It kind of depends on what the insulting agent is that caused the heart muscle to weaken. It certainly, with certain medications and treatment options, can get better. In instances of big heart attacks, that's why you hear cardiologists talk about time as muscle. That's why it's very important when you're having chest pain and suspect that you're having a heart attack to get to a hospital, call 911, and get to a hospital as soon as possible. Because once the damage is done to the heart from an acute heart attack, that heart muscle is damaged and it's not viable anymore. So that's why we want to be able to get to heart attacks as quickly as possible, and it's important for patients to get medical treatment as soon as possible when they're having chest pains and suspected heart attacks.
Yeah, that's so important what you just said. There's all the more reason to just get help right away. The sooner that you have someone look at it and have someone like you there to take care of it, the better.
Yeah, absolutely. Patients sometimes are nervous to want to go to a hospital or go talk to a doctor. They, this could just be acid reflux, this isn't anything serious, but when it's coming to your heart, you only have one, and it's very important that you take care of it. So, if you're having those symptoms, definitely call 911 or go to the emergency room to be evaluated. Better to be safe than sorry.
Yes, never be afraid to call and go for it. So,
yeah.
Well, we have a caller for you.
All right.
Hi, Shirley. What is your question?
Yes. My doctor told me that my heart has a narrow aorta, I think, and he said that he can't put a stent in it. and that I'm not able to have surgery and be put under because I might not come out. Is that true? Is that correct?
Well, there are certain situations that make patients high risk to undergo surgery and operations. Depending on where blockages are, it can be difficult to put stents in. That's something that you would just have to kind of talk to him to further characterize those risks and deciding what the best treatment option is for that. Stenting is not always the best option. Sometimes just using medications and medically managing conditions may be the best option at that time, but again, that would be a conversation that you should probably continue to have with your cardiologist to determine what the best treatment option would be.
Okay, thank you.
You're welcome. Thanks for calling.
Yeah, thank you so much for calling, Shirley. That's really important too, and I love these calls too. They come in because it's another reminder to us that everything is individual to you. There's no really like blanket answer to that, which I love her question, wanting to know, is that true that I might not come under? Come out of this? There are different factors to that, right?
Right, absolutely. Every invasive procedure carries a risk to undergo, and it's one of those things that we as healthcare providers, we try to determine the benefit and risk of what's associated with that procedure. And we don't want to pursue a procedure that the risk outweigh the benefits, because we ultimately got in this to help patients and to get better. We don't want to cause any harm or any further damage.
Yeah, which is so great. And another important message to take: let your doctor or whoever's working on you to know everything that you're feeling, everything. There's no silly thing to bring up. There's no symptom that you think, oh, that's just me. Really bring up everything that doesn't feel like it's right for you.
Yeah, there's there's no such thing as a dumb question. I encourage patients to ask your healthcare providers, questions, and what is my condition? What is my prognosis? What are things that I can do to help live a better life in the condition that you're diagnosed with?
Yeah.
So you don't know unless you ask.
Right. I think we can't stress that enough.
Right.
Do you find patients that, well, I was having this for a couple of days, but I didn't want to make a big deal out of it, or
we
I
see
didn't
it.
want to do it?
We see it all the time in the
Really?
hospital. Patients come in with chest pain for 2 or 3 days who, thought that they were having indigestion or reflux, and they come in and come to find out they had a heart attack 2 days ago, and are coming in from complications of that heart attack. So it's definitely an important conversation to have, and to talk to your healthcare providers when you're having those symptoms, because it could be something much more serious than being acid reflux or indigestion.
Yes, and so nice to find out that, it's nice to find out the reverse. Come in and I think I'm having a heart attack, and it's really just acid reflux, you're going to be fine.
Exactly.
Either way, to get an answer.
Yes.
And I found, we have another call for you. Hi, Mildred, what is your question?
My question is, I have had swelling in my left foot, leg, all the way up to my thigh, and it's pitting edema. I'm a retired nurse, but it's pitting edema, not in the right leg, just in the left. And I was wondering, could that be caused by, my kidneys are fine, everything else is fine. So could that be from some kind of heart problem that for some reason it's not working well enough to get rid of the fluid?
Yeah, it certainly could be. It's definitely something to talk to your healthcare provider about. Edema in the lower extremities could certainly be from congestive heart failure. So I would definitely have a conversation with your doctor or healthcare provider and have some additional screening done to do a good checkup on your heart to make sure that you haven't developed congestive heart failure.
Okay, well, I've had a heart cath, and it was fine.
What was that? Is that a test?
You had a heart cath?
Yes, and it was fine.
Okay, yeah. So certainly a heart cath is one procedure that they do to further evaluate for heart disease, but there's certainly some additional testing that could be done to further evaluate if you have congestive heart failure or not.
So that's a good start, Mildred.
Okay.
That came back good. So if you're still having that, yes, definitely go call your doctor and see what else it could be attributed to, right?
Definitely follow up with them, and sounds like they may need to do some more testing.
Yeah. Thank you so much for calling.
It comes and it goes. 1 week is okay, the next week it comes back.
Yeah.
Yeah, definitely go see about that, Mildred.
Okay. All right. Thank you.
Thank you
Thank
so
you.
much for calling. And so another good lead into symptoms and how many things in our body really could lead to the heart. And is it always a good question to say, is this my heart that's making this happen?
Yeah, certainly. So the biggest symptoms that we see with congestive heart failure are shortness of breath, dyspnea on exertion. You get short of breath when you exert yourself. You walk up a flight of stairs, and by the time you get to the top of it, you have to stop and catch your breath. We often see lower extremity edema or swelling in the feet and ankles. We often sometimes present with palpitations or sensation that their heart's racing, dizziness, lightheadedness, fatigue, just overall just not feeling well. Some patients will present with abdominal bloating or swelling in their abdomen. Those are all kind of warning signs that could point to congestive heart failure.
Okay, and the swelling, like say the swelling in the abdomen, is that soft? Does it get hard? Is it a different kind of swelling than just being like a bloated feeling?
Yeah, I mean, most patients describe it as a bloating feeling,
Yeah.
that they just feel like they're swelling in their abdomen. It's usually more a soft feeling just from retaining fluid within the abdominal cavity that makes them feel bloated.
Right.
Patients can retain fluid in different areas of the body with congestive heart failure, and you know, it's one location, but I would probably say the most common presentation is swelling in their legs and feet.
Okay. And what is it about the heart not acting properly that makes you swell somewhere? Just because things aren't flowing right, or?
Exactly. So heart failure, the heart muscle becomes weakened and doesn't pump effectively. And that causes an increase in pressure in the heart that causes a backflow of blood into the lungs and then to the right side of the body that causes patients to retain fluid that causes them to swell.
Mm-hmm.
There's other conditions. We kind of divide heart failure into three categories that are kind of newer terms that we call heart failure with preserved ejection fraction, meaning that their heart function is strong, and oftentimes they have untreated hypertension for a long time, and the heart muscle, the ventricle, becomes stiff and thick and doesn't relax very well. So it pumps strong, but it doesn't relax very well, which can cause fluid to back up as well. And then we have what we call a heart failure with a reduced ejection fraction, which is where the heart muscle is weak and isn't pumping blood effectively. So it's, and there's a kind of an in-between that we call heart failure with a mid-range. It's kind of not quite normal, but not quite weak yet, that we kind of put into those three categories.
Okay, we have Jim on the line for you. Hi, Jim. What is your question?
Hi. Yes, my question is, over the years, family members or friends have had the heart cath procedure, and when they've needed a stent from the evaluation of the cath, they seem to always reschedule it for a different doctor to come in to do that at a later time. And my question is are there cardiologists that will do it both at the same time, because you're already under anesthesia when they're doing the heart cath, and if you've had that discussion with your doctor beforehand to go ahead and do the stent at the same time as so you don't have to come back and find a different doctor. Generally, it's always been a different doctor. I don't know if it's their skill level or I don't know why is that occurring.
Yeah, Jim, so to answer your question, there are different types of cardiologists that specialize in stent placements. And then there's other cardiologists that we call diagnostic cardiologists that perform the cardiac catheterization or coronary angiography. And then there's what we call interventional cardiologists that do both the diagnostic part and the interventions. But it is only interventional cardiologists are the ones that actually place the stent in. So you have some cardiologists that can go in and interrogate the heart and look for blockages, and then there's other ones that are trained to specifically do interventions for coronary artery disease.
Oh, okay. And then one other question, again, from family members. The stress test, I've heard of where they run on a treadmill, and then I've heard there's also a way they do it for more senior citizens with a chemical. Are the final results just as good or the same?
Yeah, so they're very similar. A exercise stress test is where we put you on the treadmill and walk, but unfortunately, there's some conditions that patients can't walk on the treadmill. They either have, severe osteoarthritis, bad knees, or just physically can't, perform the test. So there is what we call pharmacological stress test, where we use medication to stress the body instead of using the treadmill. So the results are very similar and are both very good tests.
All right. Thank you, sir. Thanks for the program.
Yes, sir. Thank you for calling.
Oh, thank you so much, Jim. Those are great questions.
Yeah.
Think about, and we have so many doctors here, just like you are, that advocate for patient advocacy to ask the questions. And we have another caller. Was it Nina? Wilhelmina. Hi, Wilhelmina. Thanks for your call. What's your question?
Yes, I was wondering, I was recently in the hospital for heart failure, and when I was sent home on a diabetic medicine called, I think, Jardiance or something like that. Why would they put me on the diabetic medicine for my heart?
Hey, that's a great question. So there's some newer medications that we use that were originally developed for treatment of diabetes, and we later found out after the fact that they were great medications to use in congestive heart failure patients that, decrease mortality rates, decreased hospitalizations, and now have their own indication to use in congestive heart failure irrespective of a diagnosis of diabetes. So that's something that we learn out studying drugs. After they're developed, it may have been developed for one thing, but we use it for multiple conditions. So it's a great drug to use, and can be used for multiple reasons.
Okay, thank you. That makes a lot of sense. I appreciate you answering my question for me.
Absolutely. Thank you for calling in.
Thank you, Wilhelmina.
Thank you.
That's a great question, and it makes me think about something else too. How along the way with learning and advancements in medication and tests, how we'll accidentally find out that something that was supposed to treat this really cured this.
Yeah.
And that happens a lot, doesn't it?
Absolutely.
All right. Well, we have Carlene on the line for you. Hi. What's your question?
Yes, hi. I was wondering, my doctor wanted to put me on statins, and I was kind of leery about it, and I was thinking I was going to try niacin. How do you feel about that?
Sure, certainly niacin has had its role in treatment of high cholesterol levels. Again, I encourage you to talk to your doctor, about, dieting and exercising. There's, multiple modalities to treat high cholesterol levels. And, depending on how high the levels are, sometimes diet and exercise alone aren't enough, but you may need, some additional treatment to help you get to your goal cholesterol levels.
Okay. So does potassium have anything to do with having low levels? Would that be throwing things off to where you could possibly get high cholesterol too?
No, ma'am. Your potassium levels shouldn't affect your cholesterol levels.
As well. Okay. Well, I appreciate that. Thank you.
Yeah, absolutely. Thanks for calling in.
Thank you so much. Yeah, that's interesting questions too.
Yeah.
So
I'd kind of like to talk on how we diagnose congestive heart failure.
Good, thank you.
Oftentimes it's we pick it up as a clinical diagnosis.
Mm-hmm.
Patients come into the office and say, I've just been really tired here lately. I get short of breath when I walk more than a couple hundred feet. I can't do what I've done. Over the last year I've just really declined and can't do physically what I've been able to. I've noticed a little bit of swelling in my feet. So that kind of gives us cues to okay, there's something going on here. Let's evaluate. So oftentimes we order something called an echocardiogram, which is an ultrasound of the heart where we put a probe up to the chest wall and using ultrasound waves take pictures of the heart, looking at the heart muscle squeezing, heart valves opening and closing. It's a good non-invasive test to start with to kind of give us an overall picture of the heart function. And it's a very simple test to do. It takes about 20 minutes to complete, and it's completely non-invasive. So we start there, and then there's multiple other modalities. You had Dr. Catherine Gale on not too long ago. She's our new cardiologist that specializes in the advancement of all these diagnostic imaging. We use things from cardiac MRI to even stress tests, and the cameras that we use for that can give us an idea of heart function. But I would say that the echocardiogram is probably the most commonly used modality in diagnosing heart failure.
Okay. And is that something you might always start with that and then go to another modality to kind of fine tune and find out what's going on, or someone walks in and they have you skip that and just go right to a different modality?
No, I would say an echocardiogram is the most commonly used method to start with because it's easy to obtain, fast test to do, and it's non-invasive. And then depending if we find something on the echocardiogram that we're not quite sure of, then we may get something that's like a cardiac MRI that will give us a little bit different view to see if there's something else going on that we couldn't quite find out with the echocardiogram.
Okay. And set this up for us. So is this something where you're right there looking at it, or is this one of those tests where they lay there and have it done and then they find out later? Do you look and see in real time what's going on?
Depending on where it's done at, typically I would say the most average way of doing it is you come into an office or clinic, and an echosonographer does the test, and then a cardiologist reads it, usually the same day or the next day to get the results. Sometimes if there's something specific that we're looking for in doing it, the cardiologist may be there to take a look at it, but most times it's usually done electively and read, in a short time frame after the test is done.
Right. And these are something like it's they have a little time. It's just, when you're coming and you're doing this, it's okay that they get the results the next day. It's not an emergency situation. You feel like something's going on.
Yeah, and most of the time that's the way that it's done. Sometimes we see patients in the hospital that are being admitted because their heart failure has advanced and they have significant fluid on them that they need admission to the hospital to help get that fluid off, and working up then is a little bit different than in the outpatient setting, but it can be done oftentimes done in the hospital as well whenever we're trying to rule out what's causing problems for the patient.
And I remember talking to a doctor too one time. They were looking at their heart for something else, and they said they could tell that they had probably had a heart attack years before. You can look at a heart now and tell that they may have had a heart attack before with the damage in there?
Yeah, certainly, absolutely. Like I was saying, some patients don't present with the typical chest pain, and they thought they had indigestion. Women in particular often present with what we call atypical presentation. Sometimes they'll present with abdominal pain or nausea. They don't always present with chest pain, and they tend to downplay it, and they come in a couple years later and their heart function, there's a region of the heart that's not pumping as well as the rest of it that would suggest there's evidence of a prior heart attack.
And we found that symptoms are different between men and women too, which is why a lot of times a woman will go 6 years not even know she had a heart attack.
Exactly.
Right? And so is there something typical that we can look for if, like say, a woman is having this as opposed to if a man is having symptoms?
The presentation is usually very similar. Like I said, most of the time they present with shortness of breath and dyspnea exertion. So men and women typically present with similar symptoms with congestive heart failure. While the other cardiovascular conditions, they may present a little different with angina or chest pain. The presentation of heart failure is usually very similar.
And I've heard like jaw pain, neck pain, shoulder,
yes,
in
chest
the back,
pain.
and you think it's angina?
Yes, so it certainly usually presents with like substernal chest pain. Sometimes it radiates, sometimes it doesn't. Sometimes it can just present with pain in the shoulder blade or left arm pain, or even jaw pain. Everyone, unfortunately our body doesn't read a textbook of how it's supposed to present, so that's kind of our job, is to kind of distinguish what is serious and what we need to kind of further look into.
And it's a good idea, do you think, to just know your body anyway, because really what you're looking for is change.
Yes, absolutely.
It's what's atypical to you.
Right. Yeah, so anytime something's not right, your body better than anyone else, and so anytime you're experiencing something that's different, you're not used to, it's important to have that conversation with your healthcare provider about this isn't normal for me, I think something's going on.
Yeah. And you find sometimes that patients, they'll come in, they're like, oh, okay, and then they leave with so many more questions. They just were afraid to ask. Sometimes they'll call back maybe or come back. Do you think that sometimes we're still afraid to kind of take up too much time, or we don't want to ask a silly question?
I mean, there's no silly question.
Yeah.
That's one of the great things that we do in the heart failure clinic at Willis Knighton is we have a lot of support staff, several nurses that work in our heart failure clinic, and with heart failure it's evolving and symptoms change and patients retain fluid, or they get a little bit too much fluid off and things change, or they have questions, and we have a lot of support staff to be able to have patients call and be able to ask questions, or I think this is going on, I need to be seen. I encourage all of my patients to, if there's a question, please call and ask, because if you don't ask, you won't get the answer to it, you know. Or anytime you feel like you may be having a side effect of the medication, or you can't afford it, or, you know, we don't know unless you call and tell us. So I always encourage patients to be open with your healthcare providers, and don't be afraid to ask questions.
Right, and then equally important, like you mentioned, when you're on a medication. You take a medication, you try it, and do you find that some people go a little bit too longer going, well, yeah, it felt this way, or didn't feel so great on it, but I just thought it just needed time. Even if you think it might need time, if you really don't feel like this medication is, you're feeling worse, you're not really feeling better, call.
Right, yeah, no, exactly. I mean, there's multiple medications in different classes that we can use, and what one patient may be able to tolerate, another one can't. And so sometimes it's just finding the right recipe of a regimen that a patient can tolerate with, you know, side effects to, you know, that are minimized, to still be able to treat their condition we're using it for.
Right, there's always something else to try.
Yeah.
That's good. And we have Deborah on the line. Hi, Deborah, what's your question?
Yes, how are you doing today? My question is, what is the number one test you can do to tell if you got congestive heart failure?
I would say the number one test that we do is an echocardiogram, which is an ultrasound of your heart to determine your heart function. It's a very easy, non-invasive test, and that's usually the test that we use as a starting point to screen for this diagnosis.
Okay, that sounds good. Like I said, I have a stent already in my heart, and I have 2 other blockages, and my mother had died from congestive heart failure, and I was wondering to prevent that, what I need to do to make sure I don't have this.
Right, absolutely. Yeah, I would definitely recommend that you follow with a cardiologist, knowing that you already have a stent. It's really important that you continue to follow on a regular basis. Other things that you can do are minimize your risk factors for heart disease. You know, healthy exercise, eating a cardiac diet, low salt, low fat diet, you know, restrict how much salt you're taking. All those things you can do to help development of heart failure.
That sounds wonderful. I appreciate your answers.
Yes, ma'am. Thanks for calling.
Yes,
Thank you.
Thank you so much for calling. We appreciate all of our callers.
Yeah.
They're just great questions.
Absolutely.
Really wonderful.
So one thing that I would like to kind of touch on are some of the risk factors of development of heart failure. They're very similar in development of cardiovascular disease, heart disease, obesity, untreated diabetes, smoking is one of the big ones. Some of the other things that we often see are untreated hypertension that is left untreated for a long time. The heart has to work. It's a muscle just like anything else. So the harder it has to work, the more thickening that you get of the heart muscle. So that's why it's very important to follow with a primary care provider. Make sure that your medical conditions are being treated and are well controlled, particularly the diabetes and the hypertension. Cholesterol levels certainly, you know, play a role, and smoking. You know, smoking just overall is just terrible. So, you know, there's lots of resources. People that sometimes I want to quit, but it's hard to do, and it is very hard to do. But there's lots of resources available in the community to help patients quit smoking, and there's no better time to quit than today. So, you know, just reach out and to one of those resources to help you quit smoking.
Yeah, and we hear that a lot. Smoking affects every part of your body. Sometimes we think it's just the lungs, but it really takes a toll on your body. And there are resources to help you stop and replace it with something else you might like better. You never know.
Yes.
What's one final thing you'd like to leave us with today?
My biggest advice would be for patients to continue to follow with their primary care provider. Let them know what kind of symptoms you're experiencing, and receive screening for conditions that can be treated that prevent the development of congestive heart failure and heart disease.
So definitely just call and check it out, and any question you have, there's no bother.
No, there's no bother at all. It's always important to ask questions and get the answers that you need to help you make the right decisions to take care of your body.
Mm-hmm. And it's so nice to hear that don't worry, it's nothing. That's great, you know, rather than worry.
And if there's any patients, you know, with heart failure or anyone interested, you know, we take referrals all the time at Willis Knighton Cardiology in the Heart Failure Clinic. Our office number is 318-631-6400. Please call and make an appointment if you need help.
Absolutely. Well, Zach, this has been a pleasure. Thank you so much.
Thank you so much, Sherry. Really appreciate you having me.
And everyone, thank you for joining us on Healthline 3. We'll see you next time.